Hello everyone. Welcome back to the last lecture of the course Kinesiology of the Musculoskeletal System. Today we're going to discuss the knee and foot complex, and I hope you will enjoy the lecture. So let's get started with a quick anatomy review as always. I would like to introduce you to the knee anatomy. It's really simple from one perspective in terms of bony anatomy. So we have femur here involved in the joint, then tibia as well as patella. So all three bones making the knee joint, and the fibula as well is introduced on the slide on the picture. Even though it doesn't participate in the knee joint directly, it will affect knee joint movement and foot movement. So we're going to talk about it also today. If we're taking a look at anterior and posterior anatomy here, we see that both tibia and fibula connected with interosseous membrana, as we had the same membrana in our forearm as well. You can also see the line of the capsule here, both anteriorly and posteriorly. So obviously, as soon as fibula doesn't participate in the joint making, it is outside of the capsule. Here you should also put your attention on the muscle attachment points once again, as always, so you can make a pause and discover the slide a little bit more in details in order to understand the anatomy better. Overall, these bones are interconnected. We're going to discuss about this connection later on in the arthrology section, where we're going to talk about the joints. So another bone that is involved in the knee joint making is patella. So it's a nearly triangular bone embedded within the quadriceps tendon. So it has both tendon attachment superiorly and posteriorly, as well as it has its posterior surface that is covered with a 4 to 5 millimeter thick cartilage, which means that this bone actually handles severe load throughout our knee flexion and extension, and you can see that it is located exactly in front of the femoral condyles here. So these are bones that are making the knee joint, and once again I would like to introduce some important angles and orientations of the knee joint here. So we have so-called natural valgus angle of the knee, or what we call genovalgum at some point. In normal anatomy, we see that this angle is measuring between 170 and 175 degrees when measured horizontally. Now here, why it's so crucial, because it isn't just random variation, it's actually quite specific. When we see angles less than 170 degrees, we're dealing with so-called excessive genovalgum, or X knees or knock knees, and for angles more than 180 degrees, we call them genovarum, or so-called bow leg or O-type knees. And this has huge implication for load distribution movement patterns and potentially pain presentations. It's not just about the numbers, it's about understanding how this affects function and movement quality in our patients and clients. So think about how this alignment influences everything medially or laterally in the knee joint, from walking to squatting. So once again, I would like to remind that it's not just about biomechanics. Usually we see a lot of different adaptations, and overall, if the people are presented with such orientation, with excessive frontal plane deviation, we understand that there is nothing bad until we deal with severe joint dysfunctions and overloads here. This is actually all about angles that we need to know on the knee joint. So let's get to the foot. And here we see that the overall foot is made of many different bones. So organization of the bones, joints, and regions is given here on the slide. And we're not going too deep, as soon as complete anatomy is not once again presented in this course. So I would recommend to refresh your knowledge on this topic if needed. But the key regions of the foot that we need to discuss are rear foot, or so-called hind foot. So we have talus, calcaneus, and subtalar joint here. We also have midfoot, which are remaining tarsal bones and transversal tarsal joint. And forefoot is also presented here, which contains metatarsals and phalanx. And when we're describing movements and locations, we use specific terminology. So we know that dorsal means top of the foot. If someone says plantar, it means bottom of the foot. Then anterior or distal and posterior or proximal are often used interchangeably here as well. And understanding this terminology, in my opinion, is crucial for accurate assessment and communication with patients and colleagues. So once again, trying to remember when you describe any application on food to use specific terminology here. And there are also some structural similarities between food and hand I would like to highlight. So this is actually really an example of how evolution has adapted similar structures for different functions and situations. Because first key point is that both structures follow a remarkably similar anatomical blueprint. Just like the radius articulates with the carpus of the wrist, the tibia connects with the tarsus in the foot. Both even have the same number of bones, so 7 in each. And here where it gets really interesting during embryological development, something remarkable happens. The lower extremity undergoes this progressive internal rotation, and this is why your big toe ends up on the medial side of your foot. So at some point, nature is engineering its finest. And consider this functional adaptation once again. While your thumb has incredible mobility and the function, your big toe of the foot sacrificed the dexterity for stability. Why? Obviously, because it's bipedal locomotion demanded it, and your foot needed to become a stable plantigrade platform for walking and standing. And one last brilliant parallel I would like to mention here on the slide as well. When you pronate your forearm fully, your wrist movements actually mirror your ankle movements. Wrist flexion corresponds to plantar flexion, and extension matches dorsiflexion. It's a beautiful example of how similar anatomical structures can be adapted for completely different functional demands here. So when we're talking about anatomy, once again, I would like to highlight it. Here we have so-called distal tibiofibular joint, or the syndesmosis, and it contains distal tibia, which makes medial malleolus, and the distal fibula, which makes lateral malleolus. What we know about tibia is that it positions in 20 to 30 degrees torsion relative to the proximal end, like the humerus, so it's like kind of rotated. While distal tibula accounts for only 10% of body weight transfer here, but it's also important because near it located the peroneal group of muscles we're going to talk about later on. So most of these structures are really important because they obviously serve as an attachment point for the ligaments of the foot we usually talk a lot about, but we're going to see them later on during this course. Continuing the anatomy review here, talking about the foot, we have 7 main bones of the foot complex, as I mentioned before. So we have talus calcaneus here. Then we have cuneiform bones, so medial, intermedius, and lateral bone, navicular bone, as well as cuboidean bone here, located in the foot. All of them are marked in the picture, so you once again can discover them a little bit from the superior point of view. And also you can see the foot from the lateral, or this time medial perspective. And you can see that talus and calcaneus are located above each other. So what we see here is that talus mostly is convex in anterior direction for forming joints with the navicular bone and calcaneus. It's also concave medial-laterally for forming joints with the malleolus, medialis, and lateralis. As well, it has its medial groove, which is marked here on the slide with the orange line, which is a pathway for the flexor hallucis longus tendon, which is going to be really important in terms of our foot movements here. While calcaneus bone is known for its shock absorption function, so that's why it has a shape. Once again, it serves as an insertion point for plantar fascia, we're going to talk about, as well as probably one of the most known tendons, Achilles tendon, as well as sometimes it becomes the place of formation of exostosis, or so-called bony prominent regions, where we have sometimes pain around them, but probably exostosis by themselves are just bony adaptation to handle the load here and to prevent overload of the active structures here. Talking about other bones that we have on the foot, we have here navicular bone, which mostly concave within a joint with the talus. As well, it has other flat surfaces that form articulations with the cuneiform bones. Cuneiform bones forms the transverse arch of the foot here, and cuboid actually has its surfaces that articulate with adjuncts and bones. So fourth, fifth metatarsals, cuneiforms, talus, navicular, and calcaneum bones. So it actually kind of wrap within these bones.